Well, hello there, and welcome to this week's Bingham Healthcare's webinar series. I'm excited. I'm your host, Michael Brandis, and I'm excited to have Dr. Ryan Finn, a pain management specialist, with us here today to be able to talk about all areas of pain throughout the body and why it may be a good idea to ultimately get referred and be able to see him at some point. But the reason for these seminars is, as you may or may not know, Bingham Healthcare takes educating the public about a variety of healthcare issues very seriously. And in the past, we've been able to do in-person seminars with our providers. But because of everything going on in 2020, we've decided to switch over to a live or virtual format. And as you are probably seeing this on Facebook or on YouTube, please feel free to ask any questions in the comment section, and our team or we will consult with the provider and be able to provide you with responses. So again, feel free to include any questions throughout this webinar or wherever you're seeing it, and we will be able to respond to those pretty quickly. And also, if you feel like this is some topical information that some of your friends or family members might like with this webinar, please feel free to share these videos with your friends, and be sure to like the Facebook page. So I just wanted to give a really a great welcome to Dr. Ryan Finn. Dr. Finn, thank you so much for being with us this afternoon.
Happy to be here. Thank you.
So just a little bit about Dr. Finn. Dr. Finn has worked at Bingham Healthcare for a number of years, and he actually sees patients in Blackfoot and Pocatello. And his specialty is interventional pain management, and he is trained as an anesthesiologist and a fellowship trained in interventional pain management. So Dr. Finn, would you like to talk a little bit about yourself and let us know maybe where you grew up and what led you to medical school?
Yeah, I'm actually a local boy. I was born and raised here in Southeast Idaho, in Pocatello, actually. My dad is a chiropractor and has been working there for my entire existence, so somewhere around 25 to 30 years. And really, seeing him and the interaction with his patients is mostly what inspired me to go to medical school and then further that education into becoming an interventional pain specialist. So I remember as a young kid walking through the grocery stores with my dad and just having his patients waving and saying, "Hey, Dr. Finn, hey, Dr. Finn, we love that guy, we love that guy." And that just made a huge mark on me of people with chronic pain conditions. It's life-altering. It really can control your life. And I could see that the relationship that my dad was able to have with people could really alter that and allow people to have better quality of life. And that continuum is kind of what inspired me to go into the field that I did. So I did my undergraduate studies at Idaho State University. I majored in microbiology and then minored in Spanish. So I'm fluent in Spanish, and I'm happy to see any Spanish-speaking patients that are out there. Then I did my medical school down in Arizona at Midwestern University in Phoenix. Then my route took me out to the Boston area, where I did my anesthesia training at University of Massachusetts. And that was a great experience. Saw a lot of really interesting things, had some very sick and difficult patients out there. And then I did my fellowship training in interventional pain management in Milwaukee at Medical College of Wisconsin. And then pretty much from the time that I started this, my ultimate goal was to make it back home and be able to raise my family in the same area where I grew up and enjoy all the things that I loved doing when I grew up, which were skiing and snowboarding and riding my bike and fishing and spending time in Island Park and ultimately being with my family again. One of the greatest things that has been for me coming back to this area has now been able to share a lot of the same patients with my father. As a chiropractor, we refer a lot of patients back and forth, and it's been really fulfilling to see that come full circle again.
That's fantastic, Dr. Finn. Thank you so much for sharing that. I think all of our viewers out there will find that interesting and be glad that you're from Idaho originally as well. So Could you talk a little bit about some of the things that you actually specialize in? I know, for example, you have a particular interest in injections, ablations, spinal cords, and like a spinal cord stimulation. Could you just talk a little bit about some of the more general things that you specialize in, just to kind of give people a broader sense of pain management?
Yeah, so when I think of pain management, ultimately, to me, when a patient walks into my clinic, the question is not what pain do you have, but why do you have that pain? And getting to the root source of the pain is the most important part to me. And as soon as we figure out what the real reason for the pain is, then we can talk about different procedures or medications or different modalities that I have to offer that can help to mitigate or minimize the amount of pain that this person has to suffer with every day. So to me, that's the most important part, is figuring out the why to the pain and not just covering the pain. And that's why my practice, I focus mostly on injections or ablations. When an ablation means using heat or electricity to heat up an area and make that nerve stop functioning. So the injections or the ablations or even spinal cord stimulation, which is when we place some small electrodes in the epidural space or the space right next to the spinal cord, we run small amounts of electricity on there, and that helps people with nerve-mediated pain. So getting to the root of the problem, to me, is the most important thing so that I can treat adequately, rather than having a treatment of pain, generally speaking, as pain as its own entity, which is treated typically with pain medications, and we'll talk about that later, I'm sure. But to figure out why you're suffering with what you're having and then find a real treatment for that specific ailment.
That's great. Thank you. I guess that's the biggest case in medicine, is really people coming in with a problem, and then you're trying to figure out the solution to that problem throughout the body. Just to let our viewers know, so we're just doing a little bit of a general introduction of Dr. Finn, kind of talking at a higher level. And then we also have had an opportunity, people on Facebook have been really interactive when they saw that Dr. Finn was going to be speaking. And so a number of our viewers actually submitted questions to Dr. Finn, and in the next few minutes of this particular webinar, we will be going through, and I will be asking all those questions to Dr. Finn to be able to address those for all of our viewers that were engaged with our Facebook pages. Dr. Finn, the other thing that I think maybe people might be interested in to know is, what age range of patients do you see?
So most of my patients are adults, because most of the conditions that I treat are ailments of just living a busy, hardy life, and it's wear and tear on the body, and ultimately that ends up being, generally speaking, an older population. But most young adults I'm happy to see, and then anything up until you're into your 90s or 100s.
Okay, fantastic. And just to let everyone know, or to remind you again, Dr. Finn sees patients with Bingham Healthcare or Idaho Pain Group. He sees patients in both Pocatello and in Blackfoot. The one thing to note about Dr. Finn is that you will need, people aren't able to schedule directly with Dr. Finn, but if you're interested in meeting or having a consultation with Dr. Finn, I would suggest talking to another provider that you may be working with your pain. For example, like if you're working with an orthopedic surgeon, you could talk to your orthopedic surgeon about getting a referral to be able to get a consultation with Dr. Finn, or even with your primary care physician. Is that pretty, I just want to make sure that's clear, Dr. Finn, is that accurate?
Yep, that's accurate.
Okay.
So as soon as we receive a referral from another physician, we look through that referral to make sure that we'd be a good match. And if I feel like there's a way that I could be beneficial to the treatment, we'll accept you and get you scheduled very quickly.
Okay. And the other thing that I always like to bring up with our providers during this year in particular is, I was just wondering, have you been able to use telehealth visits, which is an opportunity for patients to be able to, for our viewers, this is an opportunity for patients to be able to have consultations with our doctors or providers over the phone or through a webcam. Dr. Finn, have you been using telehealth this year?
Yeah, I've actually loved being able to use telehealth. For all of my new patient visits, I do require that you come into the office for an initial evaluation, and that's because your story and then your examination are the most important things that help me make a diagnosis. And those things are very difficult to do adequately over a telehealth visit. But once we've established a diagnosis and we have a plan of care, I'm very happy to offer telehealth options. And it's been fantastic for especially my patients who live out in Soda Springs or Mackay or Arco, so they don't have to drive all that distance for a 15 or 20-minute appointment with me. We can cover all the same topics, and it's much more convenient for you.
That's great, Dr. Finn. Thank you very much. I'm glad that telehealth worked out for you. And I know a lot of our patients have been very pleased with that service, just because sometimes people just aren't even able to make it into the office in general. And I think at this point I should mention this is a service that I don't know that a lot of people within the community know, but with Bingham Healthcare, we have clinics throughout eastern Idaho, Idaho Falls, Shelley, Blackfoot, Pocatello, and and a lot of our doctors see patients in multiple cities. But the one service that we have is we actually offer a free transportation service. So if you are single or you're unable to get, or you don't drive, or you're unable to drive, our transportation service for all of our providers, if you just call when you schedule and you talk to the front office staff, whomever is scheduling you, you can ask about that service and they can schedule that for you. So I just wanted to mention that as well. So Dr. Finn, before we jump into some of the questions that our viewers have asked in the past couple of days, in general, what types of ailments do people come into you with, and maybe what are some of the more common sources of pain that you work with your patients on?
Yeah, really, we can treat pain at almost any source. So, and we'll see this with the questions that are given, is we'll have topics ranging from all over the body. The vast majority of my patients that see me have either chronic low back or neck pain. That's probably 90% of the people that I see. And the reason for that is mostly that it's just the most common pain ailment that we have. It makes up the most common reason that people present to their primary care provider is because of low back pain. It's one of the most common reasons people go to the emergency room is because of low back pain. So there's just a high incidence of that in the general population. So that makes up the vast majority of my patients as well. But we'll treat people who have chronic post-surgical pain to abdominal pain to neck pain to headaches. Really, if it's pain that's been long going and interrupting your life, then I'm happy to take a look at it.
Okay, thank you, Dr. Finn. So why don't we go ahead and move into all of the questions that people have been asking. And again, if you are seeing this, please feel free to ask questions. We are all constantly monitoring our Facebook and YouTube pages. So if you ask questions in the comment section, we will be sure to follow up even if we don't get to those types of questions today. So feel free to continue asking whenever you see this webinar. Oh, and the other thing that I want to mention is that even though Dr. Finn is answering the questions that have come in, I just want to let you know that the responses that Dr. Finn's giving is his best educated guess at this point, but it should be noted that it should not be taken as a diagnosis. It's just providing general information. You would actually need to have an in-person consultation with a provider to be able to make an official diagnosis. So I just wanted to be sure that was clear with everyone. Okay, so Dr. Finn, our first question is it best to take Tylenol for pain?
Generally speaking, yeah, that's a great place to start. So if we look at the WHO, the World Health Organization, a while ago, they actually made a kind of a stepwise method of treating pain. And they recommend that you start with the safest and most effective things first, and then you progress up that ladder as needed depending on the type of pain that you have. Ultimately, the question about what type of medicine is best for you depends on multiple factors. What kind of pain are we treating? Where is it located? What other medical conditions do you have? Do we need to be worried about interactions with certain medications that you are or are not taking? And will the medication ultimately be beneficial for you? So for example, going back to the World Health Organization ladder, they do actually recommend that Tylenol or acetaminophen be the first stage that you use. And then if you have less benefit from that, then you advance to the next step, which is the NSAIDs, or non-steroidal anti-inflammatories. Those are medications like Advil or Motrin or naproxen, things like that. And then
Does
depending on...
Aleve fall into that category?
Aleve falls into that category as
Okay.
well, yes. So beyond that, then it kind of gets a little bit tricky depending on what type of pain that you're treating. So if we're treating more nerve-mediated pain, then we would start using medications that are better for treating nerve pain. If we're treating mostly muscular pain or myofascial pain, then we'll use medications that may be a little bit more attuned to that. And then the last steps on the WHO ladder are actually the opioid analgesics. So in my practice, and I think in most practices of us fellowship-trained pain physicians, those strong opioid pain medications, as recommended by the WHO, are really the last line that we go to.
Okay, excellent, Dr. Finn. I think maybe a little bit of a follow-up question to this is, I am under the impression that it could be really easy for people to take over-the-counter pain medications like Tylenol or Advil or Aleve. Sometimes almost maybe a little bit like eating candy. I'm just wondering, how do you advise your patients or the people in general when taking too much of those pain medications is a problem, and when you should talk to a doctor, and it's a problem because I know that it affects the organs differently in people's body. How would you respond to that?
I would say that if you ever get to the point that you're taking them beyond what is recommended on the bottle, that's probably a sign that they're not doing enough for you. And if you get to the point that on your own, you're seeing that you need to take these medications every single day, even if it's exactly as directed on the bottle, then maybe we need to be looking at the underlying source and find a way to treat that source so you're less dependent on the medications. And the problem is that even over-the-counter medications like Tylenol or ibuprofen, yes, they can be purchased over-the-counter, and yes, you can essentially be your own doctor and pharmacist with that, but they're not without risk. So they all carry their own risks, and the higher the dose and the longer duration that you use any of these medications, even over-the-counter, increases the risk of having any adverse event.
Okay, and maybe for a time frame too, I would even say this is too long, but if someone were to be doing that every day, taking those OTCs for, I would say maybe 4 to 6 weeks, that's too long, right?
Yeah, by the time that you're treating the same pain ailment beyond 6 weeks, it's transitioned from an acute or recent injury and transitioning more into a chronic and potentially long-term problem. So in that window, that 4 to 6 week window is probably the best time to think about coming to see me.
Okay, great. Okay, so moving on to our next question, and this one's going to be a little bit tricky for me, so I apologize, and you can fix it, you can correct it for me. What methods are used to determine if a person has Meralgia paresthetica, and what treatments might work to reduce significant pain when standing on cement and walking 30 or more minutes at a time?
So let's take a step backwards.
Okay.
And let's define that really difficult word, which is Meralgia paresthetica.
Okay.
So Meralgia paresthetica, the most classic description of Meralgia paresthetica is of the middle-aged guy who is a carpenter. And they wear their carpenter belt around their hip and their waist all day long. And at the beginning of the day, they're doing okay, but then by the end of the workday, they've got this burning, stinging, constant pain into their thigh. So what's happening is that heavy hip belt is actually compressing on a nerve, and the nerve is called the lateral femoral cutaneous nerve, and it lives right over the crest of the hip. And with chronic compression from that, whether that be from wearing your belt too tight or wearing one of those carpenter belts, or even obesity can compress on that nerve, that will cause a worsening, chronic burning, stinging, pins and needles type sensation along the distribution of that nerve. So identifying that is typically a diagnosis of exclusion, meaning that there are many things that can cause pain in the same distribution. It can be Meralgia paresthetica. However, that's actually one of the least common reasons to have pain here. The most common thing that we see that mimics this type of pain, which is that burning, stinging, electrical pain into the thigh, is typically coming from the back itself. And it may be because you've got a herniated disc that's compressing on a nerve, maybe some arthritis that's pinching on the nerves as they exit out the back. So it could be a variety of different things. So if you were to come to me and see me in the clinic, the workup would typically be that I listen to your story, and then we do a good physical exam, see if we can elicit any specific signs, whether it's coming from the back versus this Meralgia, paresthetica, or compression of this specific nerve. We'd probably order an MRI to prove that it is or is not coming from the back, and then we look at different treatment options depending on what we've discovered from our workup. So should we decide that this is actually Meralgia paresthetica, the first line treatment would be to treat the nerve pain with any of the nerve pain medications that we typically use. So nerve pain medications come in essentially two classes. Either they were originally developed to treat seizures, or they were originally developed to treat depression or anxiety. And then over the years, we've discovered that these same medications that were originally developed to treat other things happen to work pretty well for nerve pain as well. So we would look at your medical history and decide which of these medications might be the best. Then, if the pain persists despite us trying a good dose with the medications and altering lifestyle, which for Meralgia paresthetica is the most important part, if you wear your belt too tight, wear suspenders. If you're wearing the hip belt for your construction job, well, find a different way to carry your tools. If it's caused by obesity, we've got to look at ways to lose weight. Again, we have to look at the underlying cause for treatment. So if we try the conservative things and they haven't worked yet, the next stage would be to try a cortisone type injection onto that nerve, the lateral femoral cutaneous nerve. So using an ultrasound, I can actually visualize where that nerve typically lives. We inject a small amount of numbing medication and some cortisone onto it, and we see if we can calm down that chronic irritation and inflammation.
Dr. Finn, where's that nerve located in the body?
It's typically easiest found just as it kind of pierces through the abdomen and sits right on the front part of your hip bone that you feel when you push on your belly.
Okay, great. Thank you. And thank you to the person who wrote in that question. I learned something, and I hope that that Dr. Finn provided you with some of the answers that you might have been looking for. So moving on, another question that someone has asked is, do you have a pain management plan for neuropathy?
So neuropathy is one of those things that is very difficult to treat. Again, looking into and finding out the original source for the neuropathy is the most important thing. Most commonly, neuropathy derives from diabetes, and poorly controlled diabetes at that. So the first stage to treating neuropathy that's secondary to diabetes is getting that diabetes under control. And typically we do that by working hand in hand with either the endocrinologist or your primary care to make sure we drive down your overall sugar levels. Once we've got that into a normal range and you have persistent neuropathy type pain, then we look at utilizing different methods. So again, the nerve pain medications are our first choice, and those tend to be somewhat beneficial. And then beyond that, we start getting into a little bit more invasive type procedures. So in certain people with certain types of neuropathies, there has been some evidence that spinal cord stimulation can help with neuropathy type pain. And again, that spinal cord stimulation means that we implant small electrical leads near the spinal cord and run some electricity on there, which essentially confuses the spinal cord's ability to relay nerve pain to the brain. And so that has been fairly successful with a good number of my patients, and there's some additional studies that likely will be coming out in the next 3 to 6 months, actually, specifically looking at spinal cord stimulation as a method of treatment for neuropathy.
Okay, great. And maybe to just take a step back, is there an easier way to describe or to define what neuropathy is?
Yeah, so neuropathy is underlying nerve damage from any multiple sources. And typically, it feels like a burning, stinging, constant pain. It typically gets worse at night because you're paying attention to it. And when we're describing it versus, a pinched nerve in the back, the neuropathy is usually described as like a sock-like or glove-like distribution. So the neuropathy for the hand typically starts at the tip of the fingers and works its way up the arms, just like you were putting on some big gloves. And the same thing in the lower extremity. It typically starts at the tip of the toes, and then like you're pulling on a sock, it works its way up the foot and into the leg that way.
And so that can actually present at any place in the human body then.
Yep, it can be anywhere. Most typically it starts in the extremities, in the fingers and the toes, and then works inward from there.
Okay. Okay, so moving on, another question is, I have multiple sclerosis, and my skin feels on fire with some pain on my neck and limbs. I don't like gabapentin. The person is asking for your advice.
So again, the caveat to this is that you should come and see me for official medical advice. But generally speaking, multiple sclerosis has two primary sources of pain. It either comes from the lesions, the plaque-like lesions that occur from multiple sclerosis in the brain or the spinal cord, which disrupts that nerve signaling and can cause burning pain, which is what it sounds like this person is describing, is nerve-type pain and constant burning pain. The treatment to that is likely the first line that many people choose is that gabapentin that was described, which is one of those anti-seizure medications that we also use to treat nerve pain. Unfortunately, gabapentin also carries with it a slew of side effects. Sleepiness is the most common one, weight gain, swelling in your feet, all sorts of different things. So yes, there are a variety of medications that can be trialed to try this, to try and treat that burning pain. The other side of multiple sclerosis that we see that causes pain is spasticity. As those lesions progress, the nerves start to fire differently and will actually cause spasms or contractures into the extremities or other parts of the body. And so we use different type of antispasmodic medications to adequately treat the spasms. So really treating the pain is, again, coming down to what kind of pain are we treating? Is it the nerve pain? Is it the spasm pain? And then, yes, there are a variety of different medications that we can try. Some have different side effect profiles, and we try to tailor that to the person.
Okay, great. And I was just thinking, I kind of just take multiple sclerosis for granted in the sense that I don't really know what MS is. How would you define MS to people?
So it's a potentially debilitating disease of the brain and or spinal cord, where it's more or less an autoimmune attack on those areas, and then you can lose muscle function and cause pain and that spasticity because of those body attack on itself.
Is there, are we close to understanding, better understanding MS? Is the future brighter for people with MS, or for people being able to even prevent people from having MS? Is it genetic?
There certainly is a genetic or familial component to it. We don't know the ins and outs, and to be honest with you, that's a question better answered by a neurologist who sees and treats the progression of multiple sclerosis, where my side of treating multiple sclerosis is more in the symptom management of the pain or the spasticity from it.
Okay, great. Thank you, Dr. Finn. So moving on, our next question is, how do I decide which nerve pain medicine will help most without being heavily drugged?
So I presume that by heavily drugged, they are indicating that they've tried some of these nerve pain medications before and it made them very sleepy or groggy or kind of a hungover feeling, which is the most common complaint of many of these. So in that case, I don't treat any single patient the same way that I treat anyone else. So every decision that I make is based upon previous experiences from the patient. So if they've tried a nerve pain medication and they said either it didn't work or it made them sick or it made them feel drugged, then obviously I'm not going to use that same medication on them. I will present them with alternatives, and then we can talk about the risks and benefit of trying either one of them, and we just try it and see how it works.
Okay, and to kind of add on to that, there's another question that kind of ties into what you were talking about related to how you work with your patients. Do you actually sit down with your patients and help decide what is best for them, or let them guess which one to take?
I don't let them guess.
Okay.
So I feel like the most important role that I have as a physician is actually to be an educator. And I feel as soon as I involve my patients in the decision-making process, we're going to go much further than if I dictate care to you or just let you guess what you think you want to do. So anytime that I see a patient and we decide on a treatment plan, I offer them a menu of options, and I help them understand the risks and the benefits of any of those options. And then as long as they are making a safe choice amongst those options, I'm okay proceeding, whether it be we start with the most conservative or if we go from conservative to aggressive very rapidly. But ultimately, this is a team decision, and I see that each of us have an equal say in how the care is dictated.
Okay, fantastic. Now, moving on, here's a question. I live with chronic knee pain. I feel like I'm too young for a replacement, but it's getting harder to do my daily routine. Is there a way I can manage the pain with you and put surgery off for a few more years?
Absolutely. There's multiple techniques and modalities that we have to treat chronic knee pain. So this is actually becoming more and more common as our general population is aging. We're easily living up into our 80s and 90s, and we're trying to put off these major surgeries as long as we can because usually you don't want to have multiple knee replacements in your lifetime if you don't have to. So this is a problem that I'm seeing coming in more and more frequently. So just like with many other types of treatments, I start at the most conservative, and then as we move through the conservative, we move to being a little bit more aggressive. So the first step in conservative treatment is Tylenol, ibuprofen, or anti-inflammatories, and physical therapy. There's been a lot of good evidence that good physical therapy will strengthen those muscles enough to support the knee that it can reduce the knee pain, even with underlying arthritis. If that's not sufficient, then we move on to trying some different knee injections, whether they be cortisone or steroid type injections, or even a viscosupplementation, which is more like a lubricant that we can put on the knee to help with that grinding sensation or the pain from the arthritis. Should both of those things fail, then one thing that I have to offer that you wouldn't see in like your primary care office or even the orthopedic surgeon's office is that I know a technique and I'm able to do a nerve ablation, meaning that there are specific nerves that go and carry the pain sensations from the knee joint. I'm able to identify those nerves with x-ray guidance, and through just needle injections and heating up those nerves, we're able to reduce that pain by making those nerves stop functioning. Typically, that helps people with their knee pain for anywhere from 6 to 12 months. Eventually, those nerves will regenerate and grow back together, and when they do, we can go back in and we can buzz it again. In fact, I frequently do this for patients who have chronic knee pain after their knee replacement as well.
Okay, excellent. And what made me think about earlier when you kind of try to help your patients work with the physical therapist is I had been skiing years ago, and it was that spring wet snow, and I twisted my knee, and a couple of years later it came back to really be bothering me. And I just worked with a personal trainer for a couple of years and really focused on doing more leg and knee exercises. And knock on wood, I mean, it rebuilt that muscle, and I think
Right.
it helped to heal it. And I haven't had a problem since. So I try to avoid. As a side note. Do you see a lot of people with ski accidents or from injuries from skiing?
Those typically go to the orthopedic surgeons or the
Okay.
sports medicine doctors first.
Yeah.
And then if they're having a long or difficult time treating it, then that's usually when it gets referred over to me.
Okay, excellent. So another question from a viewer is, I'm having an operation next month and my surgeon is sending me a prescription for oxycodone. I don't want to become addicted. How long should I give myself on that particular medication, and how long should I safely wean off?
So this is a great but fairly complicated question.
Okay.
So it brings up multiple concerns, multiple points that I discuss with my patients every day. It's concern of adequate pain treatment, risk of of addiction, and then treating post-surgical pain. So usually I don't give very much advice for even my own patients who I do prescribe opioids for. I don't typically write the opioids for their post-surgical pain. And the reason for that is that I really don't know what to expect of a knee replacement surgery versus a back surgery versus brain surgery versus wrist surgery. It would be unfair for me to try and manage all of those different types of surgical pains for my individual patients. So I depend on the surgeons and their understanding of the recovery process to adequately treat their patients. Now, from a general standpoint, it's okay, generally speaking, to use those opioid medications for post-surgical pain, and that you should try to use them as little time as is necessary to treat the severe pain from surgery. Some interesting studies that have come out over the last few years as we've been looking into the opioid epidemic have shown that those patients who get a single refill from their surgeon for their post-surgical pain and get that opioid medication refilled just one time have a significantly higher chance of continuing to be on opioids 1 year later. So
Wow.
typically the surgeons know this is generally what is needed for a gallbladder surgery. And this is usually the type of recovery we can expect. And as soon as you get beyond that normal expected recovery, your chance of developing chronic opioid usage increases significantly. Whether that's from addiction or whether it be from just chronic pain from the surgery itself, it's hard to delineate those without having a specific conversation. But that is definitely one thing to think about in terms of when should I be off of those medications. The real answer is at least when you run out, if not sooner.
And does the amount in a prescription will that vary, I guess, depending on the type of surgery?
Yeah, it will be very dependent on whether you've had your knee replaced or whether you've had your gallbladder out. Each individual surgery and surgeon makes that determination for their specific patients.
Okay, and I would say too that that's something that you would want to work with your surgeon very closely with to ask anybody else who's experiencing that to talk to your surgeon about being able to be prescribed probably the most minimal amount as possible. And I know with excuse me, in working with a lot of our orthopedic surgeons. In working with a lot of our orthopedic surgeons, they're actually they're trying new and different ways to be able to manage a patient's pain without even having to prescribe opioids. Is that true, Dr. Finn? I'm trying to think. I know when I talked to our replacement specialist, they do something where they do like a nerve. Is it like a nerve block?
Mm-hmm. Yeah, so this is going back to my background as an anesthesiologist, but as anesthesiologists, we have had the ability to block individual nerves for a long time to help minimize and mitigate the need for opioid medications both during surgery and after surgery as well. So generally speaking, I think most surgeons across the U.S. are looking for alternatives to long-term opioid medications for their patients post-surgery. In fact, the U.S. uses approximately 95% of the world's opioids. If you go to Europe and you have back surgery there, for the most part, your pain is going to be treated with ibuprofen and Tylenol. And so a lot of our surgeons here in the U.S. are starting to trend towards that as well. Maybe it's just a couple of days of the stronger pain medications, and then we transition to different medications, or we use alternatives like long-acting numbing agents or nerve blocks or things like that to really try and do our part to minimize the opioid epidemic, but also because the opioid medications in and of themselves are not necessarily safe either.
Okay, that's great. I was actually going to ask you because I think sometimes when people have that I would imagine that when people have that prescription, they think, okay, I've been prescribed this, and this is my only solution to be able to address any pain that that they might be having after surgery. But there are other alternatives, and as Dr. Finn said, a lot of times the doctors are now or surgeons are just prescribing simple ibuprofen or Tylenol. So just so you know that you have that as there are alternatives for that pain to be managed very well.
But again, that should be discussed with the specific surgeon. Again, each of those, even over-the-counter medications, can have effects on different body systems. And so you don't want to go and make an uninformed decision without involving your surgeon as well.
Absolutely. Thank you for clarifying that, Dr. Finn. Again, it's something that you would want to manage specifically with your surgeon to see what the alternative would be right for you. Is there anything? I guess kind of continuing along with opioids, we know that that seems to be quite prevalent in a lot of different places in the United States. How are you finding that in Idaho? And are there facilities that you work with that you can help people? Because sometimes I think maybe people don't know where they can go for help if they're dealing with an opioid addiction, or maybe they don't even know that they have the addiction. How do you work with patients in that context?
So ultimately, it depends on what we're using the opioids for, and if we've determined that they have what is now defined as opioid use disorder.
Okay.
So, how we colloquially define opioid addiction is now, in the medical studies, we're calling it opioid use disorder, which essentially means that you are using these opioid pain medications for any reason other than what they were specifically prescribed for, or in a way that they were not described for. So that can include taking too many if you were given a legitimate prescription, taking it too frequently, giving it to friends or family to use without them having their own prescription. So there's a lot of different scenarios where I can help manage the patients depending on their exact scenario. So if we're looking more at the opioid use disorder, or you feel like you're addicted, then we've got to define whether you have true addiction to the medication versus poorly treated pain and you are dependent on the medication to alleviate your pain. So those are two very different scenarios. And I can give you countless number of patients who have come into my office who have only been given these pain medications to treat, for example, their low back pain. And they never knew that there were other options. They never knew that they could have an injection or an ablation and treat their pain sufficiently so that they could get off of those medications. And in those kind of patients, I see the opioids as a ball and chain. They are every 6 to 8 hour reminder that you live in chronic pain. Every time you go on vacation, you have to count your pills and make sure you've got enough to make it through vacation, or you've got to go and awkwardly ask your doctor, can I have an early refill because we're going on vacation? Or you've got to be taking those pills all the time. Sometimes that's embarrassing in front of friends and family. So those kind of patients who are just kind of stuck on the pills because they don't know they have other options, it has been so rewarding to me over the last few years to be able to do very simple procedures, remove 80-90% of their low back pain. And then when we get their pain under better control, then I take over control of helping them wean off of the medications. One of people's biggest concern is they can tell if they miss a dose of their medications, they start having withdrawal symptoms. And those withdrawal symptoms are very uncomfortable. They can cause nausea, diarrhea, anxiety, just very uncomfortable symptoms. So once we get the pain under control, then I am very comfortable in mitigating those withdrawal symptoms, getting you off of those pain medications, and getting you back in control of your life. So that's example A. The other side of this is actual opioid use disorder or opioid addiction. For patients who have that, that's not so much of a pain problem typically, although they do correspond. But in those patients who I've identified that have opioid use disorder, then we will work hand in hand with some of our nurse practitioners or other practitioners who have a license to write Suboxone, plus get you involved with our mental health counselors so that we can treat the root cause of the addiction, which is typically mental health related.
Okay, thank you for addressing that, Dr. Finn. And I think one of the things that I really heard in there, and I think maybe people who are on opioids and having a difficult time, perhaps like you mentioned it, is not, for what I would think is there's a fear of going through those withdrawal symptoms. They would rather not have to go through what I would imagine to be excruciating or really challenging withdrawal symptoms. But what I heard you say is there are ways to manage that so it can, so it's not as potentially as severe without any additional help. Is that true, Dr. Finn?
That's correct. I won't promise you that it'll be all, roses and cupcakes, but I do, I've done this many, many, many times, and I've figured out methods to minimize the effect of those withdrawal symptoms on your life, whether it be slow rate of taper, so you come off them very slowly, give your body time to adjust, plus giving you other medications that do directly treat those withdrawal symptoms.
Okay, thank you for elaborating on that, Dr. Finn. Another question that we have is, will a cortisone injection or any injection stop spinal canal narrowing? If not, what are options to stop the process, if any, for the spinal canal narrowing? And I guess first, maybe you could define what that is, and then maybe elaborate on the person's question.
So it sounds like this person is asking about stenosis.
Okay.
So stenosis in the body, if there's a hole and there's something that's supposed to go through that hole, so for example, the spine and the spinal cord, stenosis means that the hole is just smaller than it's supposed to be. So as we age, it's very common to see that the canal where the spinal cord lives will begin to decrease in size because of arthritis, because of disc bulges, all sorts of different things can cause that. And so the next question is, as this happens, what's going to happen to me? Well, in some people it can cause pain. In some people it really doesn't. So to answer specifically the question, will the cortisone injection stop the progression? The answer to that is no. Probably will not stop the progression. But the real question is, will the cortisone injection help with the symptoms that I'm having? And in that case, the answer is maybe and probably. So when we're looking at the closing of the spinal canal on MRI, people want to be able to correlate that with the level of pain that you have. Unfortunately, the severity of the stenosis does not always correlate with the severity of the pain. So I can have, and I see, a lot of MRIs every single day. And if I only treated the patient's MRI, I would look at the MRI and I would say, look, you've got stenosis at these levels. This is where you have to have pain. And then they look at me and they would say, no, but I don't hurt there. I hurt in this other way. So just because it shows up on your MRI that you have arthritis or degenerative disc disease or a herniated disc or spinal canal stenosis doesn't mean that that's the source of your pain. It's a likely source, but just because it's there doesn't mean that it will hurt or that it does hurt or that it will hurt in the future. So ultimately, I listen to my patient's symptoms. Then we pull up their imaging and we find things that match on the imaging that match their symptoms, and then we find treatment for that. Most patients, when they're asking about cortisone shots, are asking, how long will it help? The typical answer is anywhere from 3 to 6 months. But again, that's a huge variation. Some patients, I do 1 injection and they never come back because they're feeling great. Other patients, I do a series of 2, maybe even 3 injections, and it never helps for more than a couple of days. And in that case, that's an indication that whatever is pinching on those nerves is just too tight for the cortisone to help with the inflammation, and they need to go see a surgeon. For many patients, they fall somewhere in between, where we do one of these cortisone injections every 3 to 6 months. It decreases their pain, it keeps them feeling pretty good, and then when the pain starts to return, then we have them come back in and we do it again.
So when you talked earlier about having a significant number of back pain patients, seeing patients with back pain, what are they coming to you with?
So most of them come with the diagnosis of back pain. But to me, because I live in this back pain world every single day, back pain is not just back pain. I look for the source of the back pain. So is the back pain because you've got muscle spasms? Is the back pain because you've got underlying arthritis in your back? Is it because you've got a herniated disc that's pinching on the nerves? So it's a variety of different things that can be causing the back pain. And then depending on what the specific reason for your back pain is, then we have a variety of different treatment options to help you get feeling better.
So are there, I imagine there's a myriad of reasons why people can start experiencing back pain at all stages of their life, depending on their profession, or for me, I sit at a desk a lot all day. Is there anything that you're seeing that's contributing to people's back pain in particular?
Yeah. One, we're all getting a little bit older. So just living in a world with gravity, unfortunately, we're going to have compression on those discs. We're going to wear out the discs and the joints a little bit. Other things that you specifically mentioned is yes, because most of us sit down and sit at a desk most of the day, we all lose our core strength a little bit. So our ab muscles, our back muscles, and our butt muscles are all a little bit weaker. And because of that, more of our body weight gets carried by the discs and the joints rather than being distributed throughout all those muscles. So one of the best ways to prevent or to treat chronic low back pain is with a good core strengthening regimen, including your back, your ab muscles, and your butt muscles. And then the other thing is just obesity. So the more weight that your body has to carry on those joints, especially in the lower part of your back, the more weights that is there, the more pressure they carry, and the faster they're going to wear out.
Okay, thank you, Dr. Finn. And then to kind of, I know you talked a little bit about back pain. I believe that probably the second most common source of pain that you see in patients is neck pain. Is that correct?
Yep, that's correct. And essentially, we can say that they are a continuum of the same thing. Our poor posture. So one of the most common things that I see as a source of neck pain, I call it cell phone syndrome. Because we spend most of our day looking down at our phones, and then that puts a huge amount of strain on these muscles back here in the back of our neck. And so that's one of the big reasons that I see people with chronic neck pain. Of course, we have the other things like I described for the low back. We have arthritis, we have disc herniations, we've got the pinched nerves, and all of them have similar treatments that we can offer for the neck as we do in the low back.
Okay, excellent. Well, Dr. Finn, I really enjoyed spending time and talking with you today, and I hope that our viewers will be able to take away some really valuable information that Dr. Finn has been able to provide today. I know we've talked about a number of different areas of pain and what you do to help your patients on a customized and an individual basis. I was just wondering if there's anything else that's come to your mind that you wanted to talk about or elaborate on that you might not have had a chance to.
Yeah, I think one of the biggest topics that I address on a daily basis is the use of opioid medications. And, that's a national topic, a national discussion right now. And a lot of people talk about how their providers are not able or willing to prescribe opioids because of the opioid epidemic and the DEA is on their back and whatever the reason is. But really, if we take a step back from the politics and the policies around the opioid epidemic, and we look at the science of using opioid pain medications for long-standing chronic pain, we really see that there's not a lot of benefit to it. So they've done studies where they've compared ibuprofen versus strong opioid medications for chronic low back pain. And essentially over a many-year period, there is no difference in average pain scores or functional status of the patients. Not only that, but then we start to look at the long-term side effects. So a lot of people don't understand that pain medications are not just pain medications, but they go and they can affect many different parts of the body. So as soon as you start taking pain medications on a frequent, constant basis, you start blocking pain receptors. As those pain receptors get blocked, the body says there's supposed to be pain receptors there. Let's add some additional ones. So you actually can create a syndrome called opioid-induced hyperalgesia, which means that the pain medications that you're taking make you more sensitive to pain. So things that didn't used to bother you, like you stub your toe, you trip, now because of that sensitization that you've got, turn into extreme bouts of pain. Other things that happen with long-term pain medication usage is it will alter your hormone production. For men, it drops your testosterone like crazy. You gain weight, you lose sex drive, you get moody. It will drop your bone health. It drops your immune system health and your ability to fight disease, which is so important today with the coronavirus. And then in patients who are started on opioid medication, a good number of those develop new or worsening depressive symptoms as well. So I think one of the biggest misconceptions is this is just a pain pill. It's used to treat just my pain. But as soon as we go from using it intermittently or short-term for surgery and get on that longer-term consistent basis, we start to see a slew of detrimental negative side effects that can really alter the rest of your life.
It's amazing to me that something that people think maybe is so simple, it can just have so many other effects on someone's health throughout their whole body. But thank you for providing that information. I really appreciate it. Is there anything else that you wanted to elaborate on?
No, I think we've really covered everything pretty well today.
Okay, great. I really appreciate your time, and I just wanted this to be a pretty well-rounded session for all of our viewers out there to be able to get to know and understand Dr. Finn, Dr. Ryan Finn, and that he is a provider with Bingham Healthcare, and he's here to help. Again, you will have to be able to see Dr. Finn. The best is to get a referral from another provider that you're seeing that they think you would be able to benefit from seeing Dr. Finn and having a consultation with something that you may be experiencing that's not being able to be treated in other areas. Again, Dr. Finn sees patients in both Pocatello and Blackfoot. He actually sees patients in Pocatello at 285 Vista Drive, and then in Blackfoot he sees patients in the medical office plaza, which is across the street from Bingham Memorial Hospital, which is also a member of Bingham Healthcare. He sees patients at 98 Poplar Street in Blackfoot. And I know there are phone numbers that are popping up on the screen that you'll be able to call, but just to say them verbally for one moment, it's 208-239-8023, or you can call 208-785-3800, and those are two numbers that you'll be able to reach Dr. Finn's office and clinic. And the other thing that to kind of finish up on is that if you'd like to find out more information about Dr. Finn or any of the providers at Bingham Healthcare, please visit our website at www.binghammemorial.org. Again, there's a lot of really useful information about our providers and articles, health content that you can find at www.binghammemorial.org. So again, thank you very much, Dr. Finn, for being with us today.
Happy to be here.
And we are going to conclude this. I just say that I hope that everyone out there continues to stay healthy, happy, and safe. Thank you for being with us today.